And we're rolling into endocrine and hematologic emergencies. Some of your standard competencies are going to be to apply that fundamental knowledge to provide basic and advanced emergency care, select advanced emergency care and transportation based on your assessment findings. So again, this is you being able to recognize a sick patient, do the treatments that are within your scope of practice, and then get them transported to the appropriate facility. We want to make sure that you have a significant awareness in diabetic emergencies that can cause altered mental status, the anatomy and physiology, pathophysiology, and the assessment of an acute diabetic emergency. We'll get into hematology, which a lot of this is things that you're not going to be able to test in the field for the most part, but you should have a core understanding of what's happening so that you can make a reasonable, suspicious guess about what's happening in regards to sickle cell crisis or a clotting disorder. So the endocrine system influences every cell, every organ, and every body function. In regards to hematologic emergencies, it's again pretty rare, and I would say it's probably more rare in the fact that we're unable to actually identify this particular emergency. Those who know that they have clotting disorders or that are on medications that prevent them from clotting are generally able to tell you, or will have the medication nearby so that you can figure this out. Sickle cell tends to only run in a certain patient population, and in most cases, and other hematologic emergencies are significantly even more rare than that. Looking at the anatomy and physiology of the endocrine system, there's a network of glands that produce and secrete chemical messengers called hormones. And you can think of the pituitary gland as the master gland that is telling all of the other glands to do their thing, which is going to be to create their hormones or other cells or processes. So diving a little deeper into the pituitary gland, it's located at the base of the brain. It secretes hormones that stimulate the other endocrine glands. And so that's the adrenocorticotropic hormone, or ACTH, follicle stimulating hormone, which is a hormone that triggers the ovaries or the testes to actually start producing reproductive cells. Growth hormone is used throughout the body to repair muscle and bone and organs. Luteinizing hormone is another sex hormone, which is used to also stimulate the testes and the ovaries to create reproductive cells as well. And then we have prolactin, which stimulates the production of breast milk in pregnant females. And then thyroid stimulating hormone, which is the primary metabolic hormone for your metabolism, which is produced obviously by the thyroid gland. So the pituitary gland, again, is kind of like that symphony leader, the orchestrator, and it's telling the other glands in the body to do the things that they need to do for proper metabolism and just regular everyday cellular function. And a little deeper into the thyroid gland secretes thyroxine, and which its precursor is T4, which is then broken into T3, and the body uses T3 to tell the cells to increase energy production for metabolism. This also stimulates hair growth and other things of that nature. It has a overwhelming influence on your metabolic rate in a resting metabolic state. It also secretes calcitonin, which helps maintain your normal calcium levels, where calcium can get kind of elevated or even decreased if our calcitonin is not in the right place, also stimulating the body to either strip calcium from bones or deposit calcium back to the bones in a very aggressive manner. So the thyroid gland is essential to a very normal physiologic state, and if you have a thyroid disease, you can either have hypothyroidism or hyperthyroidism. Hypothyroidism is generally treated with, again, that T4, which the body converts to T3. If you're hyperthyroid, they will go in and either chemically or actually physically ablate or destroy that gland in the neck so that they can put you on a extrinsic form of thyroid medication, being the T4 or the T3. The pancreas is an essential organ for life. It's both an endocrine gland and an exocrine gland. It secretes hormones from cell groups called the islets of Langerhans. which is, in a nutshell, kind of where we're starting to get our insulin from. The insulin is the receptor key for all cells to open up for glucose. Without insulin, the body is unable to uptake glucose, whether that be into muscle tissue for energy or to be converted into a fat store. With a diminished amount of insulin, the body will become hyperglycemic, and with too much insulin, it will become hypoglycemic. Again, if you guys remember when we went through some of the earlier lectures, the brain is the single organ that absolutely has to have glucose to function. So much so that when a person goes into a ketogenic phase, right, and that means that they've stripped all sugar from their diet or any kind of carbohydrate, over time the body will actually adapt to that, and the resultant process is called glycogenesis, where the body will recombine proteins and fats and turn them into sugars specifically for the brain. The rest of the body will run and function on what are called ketones, but in the case of the brain, it has to have sugar, and so the body actually has a mechanism in place so that it can do this. And again, the good thing is that insulin is not necessarily absolutely required to make it through the blood-brain barrier, but it is integral for it to get into like the overwhelming majority of the cells. So if we cannot have insulin in the bloodstream, then we will have, again, that hyperglycemia. So now we're looking at an illustration of the pancreas up against the GI tract, and you can kind of see where the common bile duct is coming in to empty into the GI tract, and then the pancreas has its pathways to secrete the hormones into the GI tract, which will then be absorbed into the bloodstream. If you're looking at the different types of cells, you can see that there's several different types of cells, the beta cells being the producers of insulin, and then you obviously have the delta cell, which produces somatostatin, and then some of the other glands that are in there. So alpha cells producing glucagon, which, if you guys remember in our drugs, glucagon is a synthetic hormone that we are able to give as AEMTs to get the liver to dump its last stores of glucose in a diabetic emergency. A little bit more on the role of glucose and insulin, and we've kind of covered this already, so just remember that when blood glucose levels are elevated, the body stimulates insulin to dump into the bloodstream, because we're going to use that insulin to be the gateway or the key for the receptor sites to open up the cell membrane permeability, and this allows glucose and other nutrients to actually get through the cellular membrane and feed that nutrition into the cell. When the blood glucose levels decrease, glucagon will enter the bloodstream automatically, and it will tell the liver to start to dump some of its stores. And at a certain point, the body will start actually doing, like I said, with the glycogenesis, and it will start recombining different parts of fat and proteins and creating its own glucose. Just please do remember that the brain is absolutely dependent on glucose and cannot run on any other fuel source. So when we're talking about endocrine disorders, these disorders are either by hypersecretion or insufficient secretion. So hyperthyroidism increases the metabolic rate. Some of the side effects that would be tachycardia, because we're telling the body to increase its metabolic demand. Hypothyroidism, it means that it's not secreting enough of this particular hormone, the thyroxine or T3, and that will slow down metabolism. You can see this in a lot of patients who throughout age will tend to start holding on to more and more weight, and they'll have complaints of general fatigue and the inability to lose weight regardless of diet or exercise, and that's because their underlying metabolic rate is actually dropping because of the loss of that hormone. Now we're going to roll into diabetes mellitus, and that's a metabolic disorder that is associated with a group of complex diseases, and there's several causes to that. There's no one specific that's the catch-all for everybody, but in the end result, you have a person who is not producing quite enough insulin, and so the end result is hyperglycemia, and that means that the glucose is trapped in the blood system, and because we have an inability to actually open up any of the cells to get them the appropriate nutrition, that blood level, the blood glucose level, is going to continue to rise and rise and rise until the patient is absolutely obtunded. And again, the body has no ability to switch over to ketogenesis in a rapid fashion. And typically with the patients that are insulin-dependent diabetics, that rapid shift can happen over, an hour to 2 hours, or if they have not enough insulin, this can take 2 or 3 days, and the body still hasn't kind of gotten through that barrier where it's going to start making its own sugars. And so this is a life-threatening emergency on either end, more specifically on the hypoglycemia. Hyperglycemia is characterized by polyphagia, polydyspnea, and polyuria, with polyphagia being an intense kind of sensation of hunger, and that's because the body feels like it's starving even if that person has eaten, because they're unable to get that nutrition or the glucose across to the cells, and so the cells start to panic because they're starving, and they're going to trigger that hunger response. Polydyspnea is an intense thirst, and that patient is looking to drink lots of fluid because the body now also senses that there is an excessive amount of sugar in the bloodstream, and the kidneys are going to go into overtime trying to excrete the sugar from the bloodstream, trying to maintain that homeostasis, which, if you guys remember, we talked earlier about water following salt, or vice versa. The kidneys will treat the excessive sugar like a salt, and they will resultantly be polyuria, which is where they're drinking abnormally large amounts of fluid, and then they're consistently or constantly having to urinate because they're using the kidneys to remove the sugar. Our diabetic patients end up ultimately being fairly fragile. If they started off as diabetics very young in life and they were very meticulous in the way that they've regulated their blood sugar levels, they can lead very normal, long, well-functioning lives. Unfortunately, there are a lot of people who really just don't maintain their diabetes in a proficient manner, and so those spikes in elevated glucose levels will actually cause damage to the capillary beds, and then as that blood flow starts to become a little bit more viscous, we actually start to cause necrosis in the tissue that's distal, right? Because we're not getting that ample perfusion, and so we actually start to kill tissue. And one of those things that happens in that is called neuropathy, and that's where there's nerve damage at those very distal extremities. And these patients will feel an intense tingling and burning sensation in their feet and hands. They're very quick to tell you about this. This is one of those things that they're very open about. They're at a very high risk for coronary artery disease because of this as well. And then they are significantly at risk for cerebral vascular disease or strokes, and a consistent kind of level of hypertension. Because the kidneys work so hard to excrete sugar in those particular moments where they're hyperglycemic, the kidney function will decrease over time as well. In regards to chronic and acute complications, both are associated with diabetes mellitus. And if you leave either or untreated, the organs will begin to fail and then ultimately end in the patient's death. So we're going to use a couple of terms that are kind of not really used very often, and this is type 1 and type 2 diabetes. And the bigger take-home point is the patient a insulin-dependent diabetic, which would be type 1, or are they a non-insulin-dependent diabetic, which is type 2? Insulin-dependent diabetics are generally diagnosed when they're very young. Babies to small children, it's very much a hereditary problem. Some environmental factors can play a role, but it's generally thought to be something that comes about as something that was inherited from both parents. In addition to having to maintain their sugar levels with insulin injections, they may be placed on very strict dietary controls. And now, in most cases, a lot of people tend to find that if they go into a ketogenic diet, they can control their diabetic issues much more easily than having to use the insulin, but that is more of a homeopathic remedy instead of using the exogenous insulin injections. Again, they're always going to require the use of insulin anytime they have any kind of carbohydrate. They're going to need insulin to get that sugar into the bloodstream, or I should say from the bloodstream into the cells. There can be some that are so significant that they're on insulin pumps because the insulin pump is constantly metering and checking the bloodstream and will microdose the patient with the appropriate amount of insulin. And this is for people that know that they're terrible about kind of controlling their diabetes, or they have such violent swings with their insulin management that the pump is the much safer, better alternative. Type 2 diabetes is more of a developed diabetes, and that's insulin resistance. And it's most commonly thought to come from the over ingestion of raw processed carbohydrates, where the body is asked to respond to these large dumps of sugar with excessive amounts of insulin production. And like anything else, the body will see a particular hormone at X level and it will become resistant to it. And so to do the same thing, including our own hormones for normal levels, the body will need to produce more to get the same effect, which would be produce more insulin to get the same amount of sugar into the cells. And as we do that, we're actually helping to kind of wear out the pancreas or damage it in such a significant level that we're unable to keep up with the demands. And so at that point, these patients will end up needing some kind of medication that's going to help them control that, and then they're really mostly going to control this with dietary restriction. Some of the symptoms will be fatigue, nausea, frequent urination, some frequent thirst, unexplained weight loss, blurred vision, slow healing of wounds, unresponsiveness, and seizures. Some of the treatments include weight loss as an important factor in helping control type 2 diabetes. I would suspect that that's mostly due to the fact that you're decreasing your overall calorie content, and by doing that, most people will decrease their carbohydrate load. Metformin, which is one of the drugs that helps control this, will actually get the body to decrease its ability to create glucose. If you're talking about patients who are pre-diabetic, this is conditions that are identified with people who have certain risk factors to be associated with type 2 diabetes. This is generally kind of found when you have a blood panel done and where we're doing a hemoglobin A1C level. And an A1C level is a much better identifier of a prolonged sugar level. And so when you have that blood work done, they'll actually look and it will tell what the average blood glucose level was that was kind of stored on the cells over about 3 to 4 months. And there's a much bigger window or picture, so to speak, of what their persistent blood glucose levels are. Because for the most part, when you go in and you have your blood work done, it's a fasting blood work. And so those levels can be abnormally low because you're in a fast, and they're not really indicative of what the overall picture looks like in your eating habits and what your insulin levels have been. Some of the risk factors is being older than 45, being overweight with a family history of diabetes, losing 5 to 7% of your body weight, and getting at least 150 minutes of physical activity a week can prevent or delay the onset. Again, if you guys are interested in this kind of stuff, there's a lot of research that shows that if you're on a ketogenic diet, not that I'm telling anybody to be on any type of diet, but there is some interesting studies that show that restricting carbohydrates to almost none significantly takes all of these factors out of people's lives, and they tend to be able to lead very productive lives without the introduction of medications. Now, there is something to say with how they have to live and the very specific ways that they have to eat, and so that is a contributing factor to whether or not somebody wants to participate in that particular style. Now, one of the offshoots to diabetes is called gestational diabetes, and this is particularly only when obviously a female is pregnant and they develop a glucose intolerance. And ultimately what ends up happening is there are high levels of glucose that enter the fetus, right? Because the glucose is making it across the placental barrier. The fetus then creates an increased production of insulin. The telltale signs are typically mother tends to put on a significant amount of weight. She will start to become hypertensive. The baby will increase in size at a rapid rate. So the baby will actually be overweight for what they would consider normal at the time for birth. The management of this includes some diet modification like we were talking about previously, some exercise, and then the mother being very consistent and precise with her blood glucose testing and modifying as necessary. Going the opposite direction in hypoglycemia, this is often the result of having taken too much insulin. The body very rarely produces too much insulin. So our patients that take too much insulin, they're the type 1 diabetics, they may take their insulin and just forget to eat or have some kind of distraction, or perhaps didn't eat nearly as much as they thought they would. The balance of carbohydrate versus insulin is a very delicate one, and there are some insulin factors that you have to take into consideration, and very few patients actually know a whole lot about that. They may have a 7-to-1 or a 10-to-1 factor as far as grams of carbohydrate per unit of insulin. And really, when you talk to the insulin-dependent diabetics, they just are told you should take X amount at this time or before every meal. So they tend to have a little bit of an issue because maybe they took that particular dose, but they weren't feeling so hungry. But because they were instructed to take that particular dose, they take it, and then their blood sugar drops. The counterregulation is the body's natural defense to the ability to maintain blood glucose. So this first line of defense is reduced insulin production, and then the second line of defense is the secretion of catecholamines by the adrenal gland. In patients with the type 1 diabetes, the islets of Langerhans do not make insulin. So again, this is the inability to make insulin. In patients with type 2 diabetes, the pancreas can generate it, but again, we need to remember the big difference here is it's not generating enough. And so it's either going to be modified by diet or by non-insulin medications. Most of these patients will experience trembling, a rapid heart rate, shallow, rapid respiration, sweating, and a feeling of hunger with the hypoglycemia. And that's their body telling them, I need sugar. And so just try to remember that anybody with an altered mentation should have a blood glucose level taken. And you're going to hear it yet again, right? AEIOU tips. We want to make sure we get through that for anybody that's altered mentation. Hyperglycemia and diabetic ketoacidosis. This occurs when the blood glucose levels remain elevated for a prolonged amount of time. The hyperglycemic crisis is the state of unresponsiveness, right? This is that diabetic coma. And so there's several problems going on there, and the common causes of DKA include an infection or injury, some persistent alcohol use, emotional distress, and illnesses such as stroke. One of the other things that can cause some of this is the loss of water in large amounts. Now, if you're looking at the blood glucose level, you can kind of see we have a hypoglycemic crisis when we're under 40. Now, again, use these numbers as a general kind of rule of thumb, so to speak, right? Some patients will live at 70 like it's not a big deal all day long, maybe even 60. Some patients do not feel normal at anything under 150. This is something that you should have a conversation with your diabetic patient. So the general idea is anything below 40 is a hypoglycemic event. They are borderline hypoglycemic underneath 80. And then they're between 80 and 120, they're considered normal. Elevated levels of sugar for a prolonged amount of time is anything over 120 for several hours. And then when we get to 400 or above, that's when we're going to start getting into that diabetic ketoacidosis. And so there's several factors that are going on there. So remember the polyuria, right? That's the consistent and continual urination. They're needing to get rid of the fluid so that they can get rid of the sugar. The polydyspnea is where they're drinking just as much fluid as they can get in to try to thin that bloodstream out and use the water to help kind of void the body of the sugars. And the polyphagia, because the body is no longer able to actually get that sugar out of the bloodstream and into the cell. So the cells are triggering, that sense of hunger, which is gremlin, and the body is sensing that it's starving, so it's quite literally trying to make you eat, even though you've just eaten, because you cannot get the nutrition from the blood into the cell. In patients who are hyperglycemic, if you don't give them the proper fluid rehydration because they're losing fluid from many avenues, and get them the insulin that they need to get sugar into the cells, the ketoacidosis will progress until they become altered and then go into that diabetic coma. And if it's still not rectified, they will die. So this is a comparison of hypoglycemia and hyperglycemia. You guys can take a look at it. It's in your book. A lot of this is very easy to comprehend, and you should become pretty adept at seeing the symptoms and knowing what it is that you're trying to figure out. So now we're going to talk about hyperosmolar hyperglycemic syndrome, or HHS. This happens in patients primarily with type 2 diabetes. They become hyperglycemic. Their blood becomes hyperosmotic, and then there's a very substantial lack or an absence of ketosis, right? So the body's not quite yet making those ketones because it hasn't switched over. The signs and symptoms are the high blood sugar, or the hyperglycemia. They'll have seizures in some cases and partial paralysis. More often than not, they're going to have altered mental status or be extremely lethargic. They will generally be dehydrated, have significant thirst, and very dark urine. And again, that's because the kidneys are really trying hard to get rid of that sugar. You want to make sure that you're assessing these patients like you would any other medical. You want to evaluate your scene size up and make sure that your scene is safe and that this is truly a medical emergency and not something that's being caused by an outside force, and that you have PPE on, and then make sure that you're questioning bystanders as you can, or maybe family members who have a good history. We're going to do that primary survey. You're going to form that general impression, and this is that sick or not sick, and then develop your level of response, which is your level of consciousness using the AVPU scale. Remember, altered mentation is the king of assessments. It's going to tell you if everything's being perfused, and by perfused, that's not just oxygenated, that's oxygen and nutrition on, carbon dioxide and waste products off. Then we're going to always look at the patient's airway and breathing. A lot of hyperglycemic patients have a rapid, deep respiration, and that's because they're trying to blow off the acidosis from the sugar being in the bloodstream. Hypoglycemics will have normal or shallow to very rapid, shallow respirations, and that's more because they're kind of in that shock-like state. Again, take that history. Make sure that you guys get a full, detailed history. You want to investigate the chief complaint, which is the altered mental status. And as I go backwards in time, AEIOU tips. Go through the algorithm, test every last one of those that you can possibly get. Your physical signs are they're going to guide you into your treatments. If you can get a sample history from the bystanders or family, get it, and then make sure that you're looking for any kind of medical clues, like they have glucometers or other point of care testing equipment bedside. Doing your secondary assessment, you want to make sure that you always err on the side of caution. You're going to give them a full physical assessment, always focusing on the patient's mental status and their ability to protect their own airway. If they can't swallow and protect their own airway, you might quite have to do this for them. Obtain a detailed and complete set of vital signs. This is the case where a BGL is absolutely indicated and should be taken every single time. Glucometers measure the glucose level in whole blood. Unfortunately, they're not the best as far as what we're getting, but the difference between 72 and 85 are pretty minimal. But 72 to your glucometer saying high is significant. 100 versus it saying low is significant. So, in regards to this, you guys are looking at the patient and making a determination from that point forward. Reassess your patient, make sure that you're monitoring their airway, especially if they're obtunded or if they have some kind of exceptional altered mentation. You're going to document everything that you can and rule in and rule out the things that you needed to do and your interventions. You can always, in the absence of a BGL, add a little glucose to your patient because the amount of glucose in, say, like an AMPA D50 is equivalent to about a Snickers bar. It is not going to be nearly as harmful to give them a little bit more of an elevation in their blood glucose levels as a rule out. Again, as a person who does not have a functioning glucometer, but if you refuse to give them sugar because you can't make that determination, you could end their life.